Hello, my name is Lesley Butcher. I'm one of the lecturers in adult nursing at Cardiff University. For centuries, human beings have talked about the impact of the words we use. Famous quotes from Lao Tzu, to the Buddha, Gandhi, and countless philosophers over time have all said, to paraphrase, thoughts become words, words become actions, and actions become habits. Fast forward to today, research has demonstrated that our words do indeed shape our actions. The language we use can empower or it can disempower. The words we use can dignify or they can stigmatize. Words can influence how we think about and how we care for individuals. In this blog, we're going to talk about the words we use in healthcare settings and in social care settings. And in particular, we're going to talk about people living with dementia. Now, I'm very fortunate to have today with me three very interesting, kind and clever people, Denise Shanahan, Emma Murdoch and Nigel Hullah, all of whom have an individual interest in this topic. And so can I ask you all to introduce yourselves? Denise?
Yeah, hi, as Lesley kindly said, I'm Denise Shanahan. I actually work as a consultant nurse for older vulnerable adults, obviously it's a really important topic that can be such an enabler or such a barrier, and that's probably where I come from. Being really looking forward to having a discussion with my colleagues and friends around the table.
Thanks, Denise. Emma?
Good morning everyone. Emma Murdoch. I'm the Dementia Learning Development Team Lead for Cardiff and Vale. My team support health, social care, third sector and informal carers. Really keen to explore words and language and meaning with my colleagues here today and really think about that impact that it has on wider experiences really. So thank you for inviting me.
You're welcome.
Good afternoon, my name's Nigel. I live with early onset dementia in the People's Republic of Townhill in Swansea. I was diagnosed some 9 years ago, and I'm chair of the Three Nations Dementia Working Group, and one of the focuses there is encouraging the voices of people living with dementia. Words matter. They very much matter to us. Used inappropriately or in some cases too clinically, they can be very depersonalizing and embarrassing, and make you feel a lesser person than you are. So I'm looking forward to this, and I'm looking forward to people's responses to what we say today.
Yeah, thank you, Nigel. That's brilliant. Thanks, everyone. And it's great to have you here today. Did you notice that I introduced you as interesting, kind and clever? I just thought about, as those words were coming out, I thought about, yeah, actually words are quite powerful, because I'd like to just get the audience now, whoever's listening or watching this vlog, to think about those words now. Did the words interesting, kind and clever stimulate your interest? Did you have then expectations of what you were going to hear? Whereas if I described, if I described you all in terms of, dull, not very bright people, I have three dull and not very bright people here today who are going to speak to you. How would you feel about that particular language? Would you be interested? Have I set you up to see, something in particular? So it's those type of things that is really the essence of what we're going to be talking about today. So yeah, I just found that quite interesting as I was saying that. I'd like to start with reading you a hospital scenario, if that's okay, and then just to start us off, and then we can all comment and we can have a think about the terminology used. So this is a handover situation. Inside room 3, we have a 72-year-old man who just came up from A&E about an hour ago. He's a dementia patient admitted with acopia and falls. He's been wandering since he's been up here and refuses to stay in his room, so we haven't been able to get a set of obs. He's written up for diazepam, but he's refusing meds, and because he's got challenging behaviour, we haven't been able to give it to him yet. He's waiting for a medical review. We've had to keep an eye on the door because he's been trying to abscond. try to get some mobs, but be careful because he's really quite aggressive and non-compliant. I've asked for an extra HCA to special him. So, you know, before each of our experts here think about that and give their opinions on that, I want to ask the audience to have a think for a moment. And I want you to think about these reflective questions. Firstly, what words stand out to you as being unhelpful or loaded labels? Does this description include unnecessary information or opinion? How can these labels stigmatize the person? And what words or phrases could be used to provide a more helpful picture of this man? You might want to pause the video at this point and have a think about these reflective questions before we move on. So now I'd really like to ask the panel to comment on that. And firstly, can we go with you, Denise? What do you think about that?
Oh, thank you, Lesley. I think the first thing is, sadly, that probably does reflect some of the communication that you would hear at handover at times. And there's such a lot in there, depending on how you're thinking. But the one thing that I really would like to explore is that terminology, acopia. It's like, we always say apyrexial. Oh, they haven't got a temperature, they're without a temperature. Acopia, what are we saying? Are they without coping ability? Are they unable to cope? But it's actually not. It sounds like a medical word, doesn't it? Acopia. It's not. It's actually quite a discriminatory ageist word. It's not about people not being able to cope, if that's what people are trying to sum up. It's really about looking at what their needs are. What needs are we not meeting? What is their presentation that has changed? Rather than labelling them means we don't have to think. Whereas if we actually think about their presentation, what's brought them into hospital, if it's a hospital or a care home, then we start to drill down to see what the person's needs are, whether that's medical or whether it is because things were very complex at home and something's tipped the balance. But it's something that I hear in handovers. I just think we really need to start thinking, just because it sounds medical, it's not. That's a little bit of my soapbox for today, I think.
Yeah, I mean, it's not actually a real word, acopia, is it? It's something made up to generalize about a person's situation, which then puts everybody else in the same camp, doesn't it? But it doesn't actually allow us to get to the real issue, does it?
Absolutely. It's almost, could, if we've been harsh, this laziness on the part of the clinical team, because you need to think more deeply. But
absolutely.
It looks, and it gets written down as well. So but I honestly think that people might misunderstandably think it's a legit terminology, that it's legitimate, and it's not. So it's probably one of those terminologies that gets bandied about without any thought. And that's part of what we're here to talk about, isn't it? About thinking about the impact of words.
I was just wondering, actually, Denise, so do you think then that it's just become part of a culture of language within wards that actually is just people have mirrored the use of the word and kind of taken it on board without actually questioning what it means to start with? Is that what we're thinking? It's about cultures?
I think you've probably hit the nail on the head there, Emma. It's about cultures, but it is accepted. I think that's the other thing. It's a terminology that is readily accepted by clinical staff, might be a little bit more challenged by some of our social care partners. But I think it's just that it almost looks like a real word that stops people having to question it and question its use. But, I mean, when you just start to talk about, if people understand it as not coping, that in itself is unhelpful, and it would put you on the back foot as either a patient, a member of the public, family member. It puts you on the back foot before you start, because it's almost saying they're not coping, and that then we don't think about what's caused that change. Is it a medical presentation? Is it a change in their general condition? Is there something that, like I said, is there something that's happened at home? Is their daughter maybe the main carer and she's unwell herself suddenly? That's not coping. That's something's changed. Something's broken down. Something's gone wrong.
Sorry, Denise, it's almost, I was just thinking as you were talking there, it's almost the equivalent of saying they're in hospital because they're not very well, you know, without a diagnosis.
And that is sadly sometimes difficult when people have cognitive impairment, maybe high levels of frailty. I don't think, it takes some skill sometimes to actually really look at what's going on as well. It's not a quick fix. It's something that's highly skilled, that might take a little bit more time, but it's time well invested. It's about doing the best for that individual so that they can live the best quality of life that suits them.
For sure.
But we just need to think beyond that. So if we had just a few people who thought, oh, we do use that, and I'll try not to use that in the future, and I'll try and actually make my colleagues aware that it's not a helpful description or label, because I think it is a label. That would be great. That'd be really good.
Thank you. What stood out for you in that handover, Emma?
For me, I think just the statement, he's a dementia patient, really stands out for me in just that depersonalization of the person that we're there to support, that really broad statement, that medical label. And I know, Nigel, you're quite keen to share some thoughts on that, aren't you, about that kind of dementia patient statement? What's your thoughts?
Well, this has happened to me. So it's you know, I'm a large gentleman. I've got a background. I was a Royal Marine for 21 years, so I'm naturally aggressive. I'm not in my general day-to-day life, but you know, that's the way it goes. I just think it's a misunderstanding and it's a misinterpretation. People don't have time to reflect on their actions and the actions of the people they care for. Just refer to me as Nigel. It's that simple. That's my name. That's what you call me. And you're not here to treat my dementia, because you can't, you know. But you can change the world in which I live in simply by making little adjustments to your own attitudes. One is this resistance to care is seen as a, you know, we're not resisting care. We're resisting the organization of the care. We don't understand it. People don't explain it to us. We don't have time to adjust to it. It's almost immediate. You know, you 1 minute you go on a football match, the next minute you're on a stroke unit, and there's no in between time. The words themselves are a broad brush of how people are feeling at the moment, and an inaccurate broad brush. I think if you know, somebody who is continuously aggressive would have had treatment outside of the hospital for that, and would have exhibited in their day-to-day living. So that probably would have been reflected in the medication he came in on. So to use that word that they're aggressive when they're in hospital care really misleads from the fact that perhaps the approach of the care system isn't conducive to them being, you know, peace of mind and being comfortable. We're all threatened by change, and when there's a sudden change in your circumstances, we all know how we react. Some of us react very carefully, and some of us react very inappropriately, and it's just the way human nature is. And when you're suddenly faced with a whole new regime you don't understand, having your meal times at different times than you would at home, not being able to have access to a cup of tea when you wanted, all them kinds of things would give rise to people being resistant to care. And the term, I know we're going to talk about the words later, but I think we need to talk about some of the terminology which is just bandied around. And you know, he's quite aggressive and non-compliant. What does that mean? Are you asking him to do things he doesn't want to do, or he's not used to, or is it the way you're approaching it? This is very important, that people are reflective about the way they approach people, and what's said in the staff room, the tea room, or around the nurse's station doesn't affect care. Those opinions are not taken from there and end up on the floor when they're delivering care. I think that's so important. And I believe that dementia is wholly a matter of human rights and social justice. It doesn't fit in very well with the medical model of care. So you're always going to have that tension, because you can't cure it. Nobody can cure my dementia. Right now have to deal with my dementia. I can't leave it at the door. So it's a constant factor in my life, and it is your business, and it is everybody's business. But it must be treated with respect, as you would with anyone else. I'm sure, we've all had experiences where the medical model tends to look at the deficit and not what's still there, and that's an unfortunate occurrence of what's happened here. The answer is quite simple: is that people become more informed. We attack the stigma around dementia, the misinformation, the preconceived ideas that people have, that once you've got this, you're frail and all the rest of it. One size doesn't fit all. If you know one person with dementia, you know one person with dementia.
Yeah, I think that you've hit the nail on the head there, and you've described that beautifully. Thanks, Nigel. And the two words you picked up on really are very important words, aren't they? Aggressive and non-compliant, because both of those are labeling language, aren't they? I mean, the word aggressive is actually attributing that to the person, that person is aggressive, rather than us seeing that there is actually a reason behind the behavior, that it's a reaction to the situation that they're in, that the frightening environment, the new environment, the confusion of being there, of being ill and having people that are unfamiliar around them. And and non-compliant, what message is that conveying? It's saying, we are correct, we are the ones with all power, this person is being stubborn and not doing what we are saying that they should do. So where's the person-centered care in all of that? Yeah. It just attributes blame to that person, isn't it? Saying that this person is somehow deliberately not doing this, rather than us look and sort of see, is there a reason? Why? What's happening here?
Yeah, I think you're absolutely right, Lesley. I think the words within it suggest that the person's made a deliberate choice to go against and work against. Sort of that word compliant is they've made a choice to do this, and is really kind of relying on that person to, in that moment, be able to make that factual choice, when actually we know when not just someone with dementia, but when somebody is stressed and distressed, we all struggle to make certain elements of decisions that need more support and more guidance. And actually, I think in your A Person Like Me videos, Nigel, I think you do a lovely video on the I'm not resisting you. I think that is a really, a message that I took home is actually, this is maybe me personalizing what this person is doing, when I'm need to support somebody who's in an unfamiliar, stressful situation, that is experiencing distress, and is then having, sort of behaviors that are actually showing me distress, rather than actually being resistive to me. I think it's something that we need to kind of sit back and think about, is actually, what's the person telling me without words?
Yeah. And then the problem is, Emma, that people take everything personally, and they shouldn't, because I mean, one of the clear things about dementia is that sometimes the filters come down, and we're not because there's this image of somebody with dementia, isn't it? They're either they're a nice old lady or old gentleman, who quite happily sit in the chair all day, and then there's the other view. The word dementia means demented, and that in itself gives all misconceptions. I think it's almost, you know, you're quite right when you say that people must reflect on what they say and do, and not take everything so personally. But I find that sometimes I went to outpatients. I've had a broken shoulder for almost 2 years, but because of the stresses on, you know, I just live with it. It's only, you know, it's nothing serious. It's the pain. You can live with the pain. And I eventually gave in, and I went up to a local outpatients about 4 weeks ago. And because I thought I might have to stay in, my next door neighbour drove me up and came in the room with me for no other reason than the fact that, you know, she's a nosy so-and-so. So anyway, she came anyway. And I sat down in front of the consultant, and he leaned across and he said, you've had problems with your left shoulder for a while. I said, no, it's my right shoulder. And he went, does he know his left from his right? Well, that happened 4 weeks ago.
Oh my gosh.
So that is not the rule. I'm sure that's the exception. But that's the perception, isn't it?
Mm-hmm.
That's once you've got this diagnosis, that you cease to be, you know, I don't think it you know, it's life changing, it's not life ending. And, you know, some of us maintain a certain level of function for quite some time. I mean, I'm lucky like that. Not a lot of people I work with are lucky like that. A lot of people don't. And this is why dementia is a personal disability as much as anything else. There's no broad brush for it. And but still there's this perception that the medical model rules all, and it actually doesn't. It doesn't fit in well with us.
There's that quote, isn't there, Nigel, that it's dementia doesn't rob people of dignity, it's our response to the dementia that does.
And all things, not just dementia, all things,
Yeah.
not just dementia.
Yeah, absolutely. And what you've described there in that situation is a really good example of confirmation bias, isn't it? You know, where people choose to look or believe in information that, you know, confirms their own opinion about that individual, regardless of the fact that there are other things, you know, that they could be looking at and other evidence that they could be taking into account. And I think you've got another really interesting, you know, situation to talk about, haven't you, Nigel? I remember you were telling me a while ago about how you went into hospital in that situation with the nurse and the specialist.
Yeah. I had a stroke outside Cardiff City Football Club. It's the best place to have it, really. I was going to a match and I had a stroke. And for the first time since I was about 2, I was doubly incontinent, I guess. And for a man of my age and my background and my history, that's quite challenging. You know, I felt worse about that than I did about the stroke. And the good part about that was because there were paramedics all over the place, because it's a football ground, you know. And they were absolutely brilliant. And they dealt with what they saw. And once they found out I was you know, I was responding okay. They dealt with the incontinence. They dealt with it. It made me feel a whole lot better. But it was in the back of my mind. Is this my life? What this was flashing through my mind as I was in the back of the ambulance. When I got admitted, you know, obviously the stroke team had have a look at me. I'd have a brain scan and everything, and they were absolutely brilliant. They're absolutely brilliant. But it was the actual ward that was a bit odd, because I put in a side ward, and in between sort of examinations, and there's a very busy, as you know, when you first go in with a stroke, it's a very busy period. You know, you know, the people coming back and forth, they're doing tests, they're taking blood, they're sending you off to have your brain scan and stuff like that. And when I came back, there was there's a lady in the, well, actually, she introduced her before I went off to get my to be assessed by the stroke team. And when I came back, there was notes all over my room, table, window. chair, you know, all over my room. And I thought, hang on. So she introduced herself, and she's an Eastern European lady. It's got nothing to do with it. It's got absolutely nothing to do with it. And she's bigger than me, so I was a bit afraid of her, really. And she'd been sent in to special me. So I'm here to, I'm going to be your healthcare. I'm here to special you. Now I hadn't had a word. The ward manager hadn't come in to saw me, or at least I don't think they did. Nobody had done a behavioural assessment on me. You know, I'd just done everything I'd been told to do because I wanted to get out of there. And yet they found it necessary to. Now this lady had no experience of dementia. She was at home having a dinner and she had a phone call from the ward. Can you come in? We've got somebody for you to special. And so she did it. And I just thought, what if I had been difficult? What if I had presented as being all the things that they perceive me to be? And I'd been a problem. What would have happened? Well, what would have happened was I'd probably be given a haloperidol or something to calm me down. And we all know what that leads to, you know? And I'm not blaming it, but it was the system. But at no period during, no time during that period from actually, I was in for a night and a bit, and the registrar tried to tell me that he could section me if I didn't comply. But I had to explain to him, as being an ex-human rights lawyer, you'll have a problem there, champ. And Google me. Whatever you do, Google me.
He bit off a bit more than he could chew there, Nigel.
A little bit, yeah. So I mean, but I mean, how many people would have been cowed by that?
Yeah.
How many people would have been cowed by that? But he felt he could say it. Perhaps he did think he could. I don't know. But I knew he couldn't, and leave it at that.
And what words there, Nigel, looking back at this scenario, what words were used that could have led to that situation being happening? The words in there: absconding. He's at risk of absconding. That custodial language being used.
You can't abscond if you're in a former patient. How can you abscond? You can't do it.
That word is used, isn't it?
I mean, he wants to leave the room. Okay. Abscond, well, it's got an element of breaking rules, doesn't it? You know, it's sort of, you know, I'm curious. I'm a naturally curious person, and you know, if I go to a hotel or something, I examine every bit of my room just to see if anybody's left anything behind. And then I'll go down into the fire and I'll look around there, and then I'll go to the bar and I'll see what whiskies they stock. I mean, am I absconding? No, I'm not. I'm just examining, you know, I'm just checking out my surroundings. And, you know, if I'm in a room in a hospital, if I'm in a side room in a hospital, I'm going to be bored because I'm isolated, but B, I want to know where all the fire escapes are. I want to know where the loo is. I want to know, you know, that's standard stuff. Just because I don't say it to somebody doesn't mean that I'm running out through the front door, does it?
Yeah.
So, but it's almost a criminal word, absconding. You know, you abscond from jail, you abscond from magistrates, abscond from custody. You don't abscond from a medical ward of a hospital.
Yeah, and in a similar way, what do we think about the word wandering?
That gives, you know, let's quote Tolkien: "All who wander are not lost." You know, and you know it's true. I mean, just because you're having a little walk around doesn't mean that you're not any good, or you're having a moment, or you might be having a moment. It's possible, but establish if you are having a moment first. Just ask, what are you looking for? Don't you like your bed? I'd find something. What I find is that, and speaking to your nurses in particular, sometimes that you find that nobody's actually experiencing distraction. Everybody's experiencing confrontation. How do you talk somebody down? How do you get the best from people? How do you get the best from yourself by getting the best from the people that you care for? It's easy to restrain people. it's a piece of cake. All you have to do is take away a walker, jam a bed against the window and put chairs either side of it, put somebody in a bed and raise the cot sides. That's easy to do. Or physically restrain them by holding them on the floor. That's easy to do as well. The difficult part is finding out why people are wandering. Some people do wander, you know, they try to get home, and it's you know, it's bringing together that need to care for vulnerable people and allowing them to sort of exercise their rights as human beings. It's that fine balancing act.
Mm.
It needs a more nuanced approach than just saying, if you don't stay in bed, you're wandering.
Yeah, I think sometimes it's the implication, isn't it? It's implying that the person has no purpose to their movement and they're just walking around aimlessly, you know, rather than acknowledging that that person's got a purpose for their walking. While you were talking there, I noticed you used the word cot sides, and I want to ask Denise now, because I know we've had this conversation before, haven't we?
Yes, I mean, the third term now is bed rails, and that actually, the terminology came about from focus groups that I think it was one of the national patient safety agencies a few years ago, did some scoping exercises with older people, and they really did not like the term cot sides. It's quite childlike, isn't it? So, and bed rails is a more acceptable term to people. But actually we overuse them. That's another thing. We describe them, and in staff still use the term cot sides very frequently. But it does, when you think about it, you use cot sides for the child, not an adult. We use bed rails to stop people slipping, sliding, or rolling out of bed if they need it. But we do default to raising them as well. So it's not just the terminology we use, it's how that terminology probably translates into actions. And so it's all that reflection, isn't it? And one of the things when I was listening to Nigel earlier, we seem to use these labels as shortcuts to doing assessments. Just short, you know, as a shortcut, or almost like it's almost like a defense mechanism for staff, isn't it? So if you label somebody, you don't have to think about it too much, which is not great for person-centered care, but it's almost like a coping mechanism potentially. I don't know, just something that struck me when Nigel was speaking. It's not something that I've considered except for maybe acopia before. I don't know what anybody else thinks.
I think permissions, giving people permissions to question the words they use is something we really do need to think about in our development and delivery of services. Is actually how empowered do people feel to question ourselves and others around our language. I absolutely agree with you. The term cot size is derogatory. It's taking on the parental role, and the difficulty of taking on that parental role is that you can build a culture of care around that parental role, which does not recognise the person as a whole and recognises them as an adult. But I think that the permission to question and challenge our own thought processes and values, I think, is something we need to think much more in detail about. Because I'm really curious, and as Nigel was talking, I was really, through the whole statement of the scenario, I had a sense that it was somebody giving somebody, it was a conversation based on a warning. So be careful. There's aggression. And the end statement of try to get some obs, but be careful, as he's quite aggressive. In no other situation in a healthcare setting would I warn somebody like that unless there was a true danger to the person. The person had no, it was as if that danger warning, I'm labeling you, and then I'm sharing that warning with others. If somebody gave me a warning, if somebody said to me, right, that car's got, you know, it's got a bomb underneath it, don't go and drive it, would I go anywhere near that car? I wouldn't go anywhere near it. I would actually be quite resistive to going towards it and would probably put up quite a protection of myself. for that. And I'm just wondering if we do, in the subtleties of what we say, I think we don't mean to, but we might put subtle warnings on things that actually do transfer into products and supportive care. I don't know what you think about that. I just think that the subtleties in what we say actually will shape a whole interaction, because we want to keep ourselves safe and keep others safe. Yeah, so it kind of then comes about, I'm a little bit more protective. I don't know what you think. What do you think, Nigel?
Well, I think it's inevitable that people will consider danger before safety, because danger's exciting, isn't it? Oh, there's a guy in bed 3, he might kick off. And to certain people, that would be a challenge, wouldn't it? You know, I'm going to go in there, I'm not going to get any trouble because your opinion is rubbish. And I go. But really, if you talk about people in those terms, you've got to have evidence for those statements. You know, why do you think? What I always put myself in a position where when in the services we were put in dodgy situations, but we always knew why they were dodgy. We always knew where they were dangerous. We always knew where they were difficult. And when they weren't any of those, they weren't. It was that simple. And even in conflict areas, you know, there were safe places to go. And not everybody who has or is going to exhibit aggression or non-compliance is going to do it on a regular basis. And it's understanding what makes people unhappy. A lot of people don't like being woken up at 7 o'clock in the morning to a lot of clatter and noise. But the organization is set for that. Yeah. So if the organization is causing the unhappiness, then try as much as you can to make the organization fit the needs of the people it's there for.
Can I just say, I loved what you picked up on there, Nigel, because you didn't mention about challenging behaviour. You used the term challenging environment.
Yeah.
Which came from, so absolutely, we're shifting the perspective of, for the organisation, it's a challenging behaviour. For the person living with dementia, it's a challenging environment. And once we can start to understand those and actually see it from the person's perspective, oh yeah, this environment is challenging. Listen to the noise, listen to the people talking, listen to the buzzers. I think that was a wonderful way to kind of flip that, Nigel, and a real kind of, because as soon as I heard you say that, oh yeah, gosh.
Absolutely, we're looking at the underlying reasons, aren't we, rather than attributing a label and blaming behaviour on the person. You know, I know challenging behaviour, the terminology is very outdated, but unfortunately, you know, it still gets used, and I still hear it being used, even though academics say, oh, that terminology is outdated. Well, yes, we know, but why are we still using it? You know, people are still using it in practice, and we need to stop. We need to think what Nigel was saying about thinking about the challenging environments, or what are we doing? How are our actions impacting upon that person? You know, yeah, absolutely. What do you think, Denise?
Yeah, I mean, I've got so many scenarios in my head, and like most people, you know, I come from a professional background, but we're socialised in many ways. And you know, I've had family members who live with dementia, and it's yeah. But I was just thinking about even older people, or even ourselves. If I was in a clinical environment, I'm scared if it's about me. I'm scared if it's about my family. And I know as well, as I'm relatively articulate when I need to be. I've got a healthcare background, and when my mother-in-law was in hospital, I had difficulty getting them to listen to what her changes in presentation were. And if I can't do that, and I know the buzzwords, I understood the background, I understood the presentation, I was so taken aback that I couldn't get anybody to listen to me. With my, not instead of my mother-in-law, she was there. It just must be so difficult when we're not seeing the person as best we can.
it promotes a very paternalistic relationship between, you know, nurses and patients, doesn't it? So, you know, on that sort of vein, I wanted to pick up on one of the other words, and it's quite a subtle word within that scenario, and people listening might not have picked up on it, but the word refusing. So, you know, the word refusing, it's very subtle, but it sounds like the person is being difficult, rather than that they're declining that medication for a reason. You know, it's sort of implying that you know, we're right, they're wrong, they're not complying, they are refusing, rather than say they're declining, or they've said that they do not want their medication at this point. You know, can you see? Does anyone else want to pick up on that?
It's a tricky one, isn't it? But you're right. It's that power imbalance. That's what comes from it, isn't it? Where you're saying we're right, you're wrong. This is the treatment you have to have, rather than, you know, as we talk about co-productive, shared decision making. The care tends to be professionally weighted rather than person-centered. I think that's what refusal rather than decline says to me. I don't know about anybody else.
You know, I take your point, Denise, that the imbalance is there simply because there is still this view that we know better than you do. You know, because I've read more books on it than you have. Well, my answer is I've lived it. Have you? That's my view, and that's not always the best example to use, because I've just lived my bit. I'm an expert in my bit, you know. But this professional, this weighing towards people being more skilled because they've got more qualifications doesn't work out in practice.
I think one of the things that helpfully will help us challenge this is that those conversations about what matters to me, and what matters to me right now. If we could start having those simple conversations, we could be far more person-centered, with shared goals, shared decision-making, shared understanding.
Yeah.
And that's not a hard one, is it? What matters? Yeah. What matters to you?
And non-judging as well. I think that kind of he's refusing has elements of judgment to it. You go, do you know what? If I went into hospital and I'd had a fall, I would choose diazepam as well, because I would probably be more likely to have a fall if I got given diazepam. But it's just that it feels we have to be non-judgmental and kind of step back and have that horizon view of, well, what's going on for this person, rather than judging them and kind of pointing the finger and kind of saying, oh, you know, he's non-compliant, he's refusing, he's, you know, and actually it's really stacking up, isn't it, those kind of negative derogatory words towards somebody. Was I use those words if I met somebody in a street? And no, I wouldn't use those words to describe them to the next person. But because I put on a uniform or I'm in a care setting, then that gives me the right to talk like that. It doesn't. It absolutely doesn't. I think we have to remember, you know, sort of there's a reason we work with human beings and we come into the healthcare profession is because we should value people as human beings and their right to, you know, he has it until otherwise he has the right to refuse medication. So I think it's just about making sure that we kind of have that non-judgmental attitude towards things and make sure we use those words. So hopefully it's, whereas like a smile can be contagious, positive language can also be contagious as well, and kind of make sure that we champion those kind of individual terms that describe people and their situation and their circumstances and their current and their moments as well. It's kind of, well, this is how this is at the moment. The person's not always, he might have been aggressive because he could have had a delirium, but that doesn't mean he's always aggressive. We treat the delirium, the person's well again. So I think it's just making sure we don't generalize those terms, because those terms stay with people.
Yeah, and there might be people at the moment who are listening to this or watching this vlog and thinking, I think you're being a bit pedantic, you know, maybe you're picking up too much on some of these words. Does it really matter what words we use? But I ask you this, have a think about if you went to a friend's house and they said, would you like a cup of tea? And you said, oh, no, thanks. So don't want a cup of tea for whatever reason. Then later on, you heard that friend describe you to another friend and said, oh, she refused a cup of tea at my house. How would you feel about that? Did you decline the cup of tea, or what's the difference between saying, oh, you know, we were going to have a cup of tea, she didn't feel like a cup of tea, rather than say she refused that cup of tea? It sounds like you're insulted, doesn't it? It sounds like that person has been so rude in refusing something. So that's why, you know, it's important to think about the kind of language that we use, isn't it?
Yeah, I mean, and you can bang on about this till you're blue in the face. Unless there's good leadership, these things won't disappear. People will revert back to that because, as Denise said, and as Emma has said, it's the easiest way to describe difficult situations. And it's a get out. Oh, I can't do anything with him, he's aggressive. Well, hang on. That's, you know, it's a catch-all statement. And I honestly believe that these changes have to come from the top. And people have to be enabled to make the changes in their own practice by loosening up a little bit on you know, often you student nurses, when we do your sessions, and they say, oh, well, you know, we're told off if we talk to people. What you do with talking to people, there's work to be done. Well, come on now. I get it, but it isn't talking to people, isn't the communication 90% of what people do? And the other 10% is actually physically doing things, you know. And one of the things that, what, you know, Emma and Denise have both alluded to the fact that perhaps our communication isn't as, perhaps the communication is as good as it should be. Well, I would say it's nowhere near where it should be. Because you could communicate just a look, a smile, a touch, a little pat on the hand as they walk past the bed. You know, that's not going to take a huge amount of your time, is it? But it's humanizing what you're doing. One of my friends who Debbie, who went up to see her father who's got dementia. She lost her way, and she asked for some directions of two people, and in the hospital, and she said, I'm sorry, she said, I'm living with dementia, I've lost my way. Can somebody take me to ward, whatever it was? And the one lady said, yeah, okay. So they took her to the ward, and as she was introduced to the ward, she said, oh, she said, this is Debbie. She said, you know, she says she's living with dementia and she's lost her way. That devastated her. That one sentence devastated her. And she turned around and walked out, and didn't get to visit her dad. She couldn't face her dad, all tearful. Now, that nurse, that person that did that probably didn't mean anything by it at all. In her head, it was right. You know, because that's the way she'd heard other people talk. But it's not, is it? You know, it's dehumanizing our conversations around people.
Yeah, and anyone can lose their way. So what she was doing there, she was attributing the getting lost to the dementia rather than to the situation. So again, it's seeing the dementia and not seeing the person. I quite often lose my way, and I'm not living with dementia. So
Yeah.
if I lost my way, probably I get, well, she's lost her way because she's blonde. but you know, hospitals are confusing places sometimes. It is difficult to find your way. I get lost all the time. Yeah, it's about not labeling that person as saying this is the reason for the dementia, is the reason for their behavior.
Yeah, yeah. But it's the language around it as well. I remember when I was on my diagnostic pathway, I was interviewed by a psychologist, and she said, can you give me some of the examples of some of the things you're forgetting? No, she meant well. She meant well. But just imagine me sat at the other side of the desk at that statement. I went, what? And I think that obviously that when you're dealing with vulnerable people, language is so important, and because it doesn't really matter what the vulnerability is, it could be sort of homelessness or whatever. That language is so important in when you're talking to people in and around those issues, because the labeling comes up so quickly. And then you get the withdrawal, then you get the non-compliance, and sometimes you get the aggression. You know, how dare you speak to me like that? Who do you think you are? You know, I've seen it. I've been there when it's been done, and we kind of dismiss it as saying, oh well, they probably didn't quite understand what was going on. No, they did understand fully what was going on, and that was the reaction.
I think you've made a good point there, Nigel, about I think most people do mean well. Nobody wakes up in the morning and says, right, I'm going to make someone's life absolutely miserable today. I'm going to describe them in terminology that makes them feel absolutely rubbish. But it happens. And, you know, I think none of us here are blaming and saying, you know, people are wrong, but we just need to be aware of the language that we use. And I want to move on to an example, if that's all right, a care home scenario that I experienced a few years ago. This was a situation where I was working as an agency nurse in a care home while I was doing my job here, and I was doing the drug round at the time, going around, and a healthcare support worker came past me, and as she was wheeling a lady who was sitting in the wheelchair, and a lady, we'll call her Margaret. And the healthcare support worker said to me, oh, Lesley, look at Margaret. Doesn't she look pretty today? And I looked at Margaret and I saw she's got makeup on. She's got her hair done nicely. She's got lovely clothes on. I said, oh, yeah, Margaret, you look lovely. Yeah. And Margaret's reaction was to beam with pride. She was like, oh, I've been paid this lovely compliment. And then in the next breath, the healthcare support worker said, I love dressing them up. And Margaret visibly shrunk at that comment. She just felt like, I can't speak for what Margaret felt like, but I felt embarrassed by that. And that's a subtlety. And I'm sure that healthcare support worker meant well, but by using that word, they, you know, as in, I love dressing them up, you know, Margaret became a non-person. She became part of a group. It wasn't about Margaret, it was about me. And I had this picture in my mind of a child dressing up a Barbie doll. You know, at the time, it's like we dress dolls. We don't dress up people, we dress up dolls. This is a person we've got there. And, you know, again, people who are listening to this probably might see this as a little bit pedantic, but it's important. And I have to say, Margaret looked mortified. And it made her feel awful. She visibly shrunk. Does anyone else have any comments on that?
I think that's quite a powerful illustration of possibly well-intended actions having what we were presuming was quite a significant impact on that individual's perception of themselves and perception of the interaction that they'd had. So, I mean, that would make you feel sad for the rest of the day, isn't it? If not for days or weeks. I feel sad listening to you talking about that, because I can sort of feel how I would feel, or how I'd feel about anybody, your family or people in your care. It just demonstrates, doesn't it, how subtle things can hurt. So that's how I think you were describing the ladies hurting. I think it's a really powerful example.
Yeah, it's making it about the person, isn't it? We all can use language that is going to offend or hurt, and we don't mean to do it, but I think it's just about being aware and trying not to do that. you know, thinking about is how would I feel if that language was used about me. Nigel, that scenario, how would you feel if that was used about you?
You see, the lady meant no harm by saying that. She thought she was working within acceptable parameters by depersonalizing us. Oh, don't you do, you know, two statements I hate. One is living well with dementia, which is an impossibility. You can't do it. You can live a quality of life with dementia, but you can't live well. And the second one is, aren't you doing well? Condescending sort of drip. The lady who actually said, I love dressing them up, you know, she's not being hurtful, but that's where bad care starts, where that conversation is permissible. Because once the conversations become permissible, actions become permissible. And you have the terms of, you know, being used, you know, double handling. And what does that mean? You get the term. It's all here. And you get the term frequently incontinent. You know, I mean, what does that mean? Does that mean that, you know, there's something bad about being incontinent? It's far worse to be incontinent and have to deal with the incontinency. Trust me. And I think the depersonalization of it is kind of something which is present throughout our journey, really, and then it can happen in all unexpected places. I mean, when I was traveling to London before lockdown on a fairly regular basis, I used to sit in the disabled seats in the train, because, as you know, the train from Swansea is pretty empty. By the time he gets to Cardiff, he gets full. So I used to sit in the disabled seats, and I had a disabled car, but I'd lost it. And so I on this particular morning, I used my my Alzheimer's disease. It may surprise you to know I've got memory issues. You know, I can't remember. So the guy came up to take the tickets, and I looked up and he had a Dementia Friends badge on. I thought, oh, there we are, marvelous. So I sat there and I gave my ticket and I showed him the card. That's why I was sat in the disabled seats. So he looked at the card, he looked at me, he looked at the card, he looked at me. He said, "You got dementia, have you?" I said, "Yeah." He said, "You don't dress as if you got dementia." So I thought, then I've been diagnosed for 5 years. I didn't realize it was a bloody uniform. But he didn't mean anything by that. But his perception, and he'd done the Dementia Friends course, or at least he wore a badge, who said he did it. And the point is you can do as many courses in the world. If you don't have a basic understanding of how to communicate with people, you're going to have an issue. And this lady obviously didn't have an understanding on how to communicate. Yes.
I think what that explains as well, Nigel, again, quite innocently but powerfully, is we need to think about the meaning of the words we're using. We need to think about those conversations. It is about our values. That's what's so important, to give people maybe some time to reflect on the language they use, because it does carry values
And messages.
Yes.
And
yeah. I think that, you know, I think we started out with that, but that's a really, again, a really powerful example of those values and messages that were incorrect.
And of course, the other thing is, of course, people are quite taken aback. When you say to somebody, "Hello, I'm Nigel, I'm living with dementia," people tend to look at that, and I don't know why they look down. Are they going to find the answer to something on their shoes? I don't know. But most people go, "Oh, really?" And you think to yourself, well, hang on. Terry Pratchett had a wonderful saying. He said that he was, when you battle dementia, nobody takes any notice of you. If you battle cancer, you're a hero. if you battle dementia, you're just a doddery old fool who won't take no for an answer. And he's, you know, he's so right on that. And my mother also had a saying that if people only talked about what they knew, this would be a very quiet place. And,
I like that.
And it would. He felt he had to say something. All he had to say was, "Oh, thank you, sir." But he felt empowered to say something, and he had to say something. And of course, it was rather badly for him.
It's so interesting, actually, because as everyone's been talking, I've been thinking about language and dementia, and people, the two problems as I see them are these two extremes, that people with dementia are either labelled with something as a wanderer, as a person with challenging behaviour, as resistive, or, you know, as aggressive, whatever, or confused, or there's this other aspect in that there's this depersonalization, that they become no one. They're someone, usually a negative someone, or they're no one. They're them, or they're, you know, I mean, this can apply to other people, not just people with dementia. I'm thinking about in the care setting, words such as hoists or feeds. So people quite often say, "Oh, I've got 3 feeds to do," you know, referring to people who need assistance with eating.
Yeah.
You know, they're not feeds. They're a person who needs assistance with eating. You know, anyone else want to come in on that?
Yeah, I was just thinking about when I used to hear quite a lot when I was in the care setting, doing the turns. Yeah. So you people knew exactly where you were going. They knew the task you were going to do, but you didn't talk about individuals. It was, "I'm going to do the turns." It was kind of like, oh gosh. And now when I sit back and look at it, and I think of that generalization that I used across statements, and I think I absolutely agree. I think that once it becomes a part of the language culture of an area, it sets kind of a level of what's acceptable, when actually what we want people to do is kind of have some reflective thoughts on the powerfulness of their language and feel able to call it out, take a time out, have a reflect, have a discussion with each other about, well, what do we mean when we say this? Because we know what it means to us, but actually, does it have a deeper meaning? And how can we bring meaning to it? I think is something that I'm curious about. Well, how can we bring meaning to words? Because I know particularly when we a lockdown, lots of us had a sense of having our individuality taken away from us because of the needs of society, were that we were restricted in one way or another. We pretty soon wanted them back. So I think, sort of somebody with dementia has the same aspirations as us. What we need to help them do is to actually help them connect with that and advocate for them to keep a sense of that self and that I. This is me, this is I. Because they need our support to be able to do that. Because as we know, as dementia progresses, people with dementia are going to, some people with dementia are going to lose that language ability. So I think it's about making sure that we understand where our level is of our values. I think.
I couldn't agree more, Emma. I could. One of the things I always say to people when I'm doing these kind of things is that we all share the same space. It's not as if we all got different pathways. We all share the same space. Just I couldn't agree with you more on that. And what you said, Denise, about the way people's words turn into actions. I think that's so powerful because it does. It does. If you keep on using terms which are derogatory, your practice becomes derogatory.
Yeah. What about the words, Nigel, around the word, describing you with dementia? What about dementia patient or suffering with dementia? Or
Call me Nigel. Is that difficult? You know my name. Call me by it. Yeah. I mean, is that difficult?
Yeah.
Is that so hard?
Mhm.
You know, if you want to call me Mr. Hullah, fine, call me Mr. Hullah. I mean, I don't care about that, but I mean, you know, just call me by my name. And when I'm in your hospitals, I'm not there for my dementia. I'm there for whatever's wrong with me. So if you are going to label me the man in bed 3 with a poorly shoulder, or the man in bed 3 with a stroke. Nigel's been admitted he's had a stroke. Oh, by the way, he lives with dementia, because that's an important piece of information that people need. But don't use that as the first non-declare that you say, oh, well, listen, we got a new patient, he's got dementia. I'm not there for my dementia. And there's nothing you can do. You're not going to be able to give me a pill or an operation or anything that's going to cure my dementia. You may give me some activities which will help allay further, you know, a further deterioration in my well-being, and I'm always grateful for that. But just call me by my name. Just call me by my name.
Absolutely. I mean, it's one of the things that I have a bee in my bonnet about, people being called a dementia patient, but they're in with a broken leg.
Yeah.
So, you know, they're not in for their dementia. You know, they might be living with dementia, but they're not a dementia patient. It's the other thing I know people with dementia don't like is the suffering with dementia. This person is suffering with. What do you think about that?
Well, I used to argue non-stop with Nick Johnson in particular about this, because he was anti that word, and I thought they were being a bit precious. And I remember the first time we had heated arguments, and I didn't think that mattered so much, because if you've got dementia, you know, your family around you suffer in particular. And then I thought about it, and I thought, no, that's the wrong word to use. Absolutely. But oddly enough, I interviewed for a well-known national charity. I was on their interview panel for a senior post there, and 4 of the people who came up for that post used the word sufferer, and they were applying for jobs. And you know, in the end, I just said, look, you know, you can't use those words. You know, you can't. But you know, I mean, it's all about this labeling thing, isn't it? You know, I mean, why do we need words? You know, if I want to tell you I've got dementia, that's up to me. And I think it's relevant because, you know, if I go to see a GP who doesn't know me, I say, look, you may not know this, but I'm living with dementia, and I find some things difficult. Just to put people on their guard that they might be having a bad day, for instance. That's okay, but to have this label foisted on you because it's seen as being helpful. It's helpful for me to say you're a sufferer. No, it isn't. What's helpful is to say that I'm Nigel living with dementia. And that's you know, that's helpful, because then it means that it's more than just suffering. You know, you know what's very hard to get over to people is the good day, bad day lottery with dementia. It's very difficult for professionals to understand that, because they very much deal with what's in front of them. And you know, they don't grasp, even consultants don't grasp that some days, you know, some days I get up in the morning and the coffee machine confuses me. It does. Yeah, I just can't work it out. You know, and what I do is sit down, I drink a glass of water instead, but you know, because you have to. You know, sometimes my shoelaces confuse me. I look at them and they you know, and the world's an alien place to us guys, us people living with this disability, as it is with people living with autism, as it is with people living with acute schizophrenia, as it is with people with MND, as it is with people with Parkinson. The world becomes a very hostile place sometimes, and it isn't helped by labeling it by saying this is a generalized term that every day is like that. Some days it's not. Don't suffer a bit. I have a better life than some of you probably. But saying that, there are days when, yes, I do suffer, but that's not a general description of my day-to-day, you know.
I guess it's implying that you're always helpless, isn't it? It just fortifies that stereotype that, you know, a person with dementia is generally incapable, rather than that you do. I think that's a good point about the good days, bad days. Emma or Denise want to comment on that?
Funnily enough, I was just thinking, you know, years ago, my practice was in stroke care, and that quite a long time ago, stroke survivors were challenging that terminology. They weren't suffering with stroke, they weren't stroke sufferers, they were stroke survivors. You know, they didn't deny that they had a stroke, but they were living to tell the tale, and they were getting better, they were getting stronger, and it just changed that. It just changed perception. Again, it's just that power, isn't it, behind the words?
Yeah.
And I think it's about understanding as well the time and effort and energy it takes for somebody living with something long term to feel like they've got to go into situations and help prep other people. I think that's hard. And I absolutely agree with Nigel. Good days and bad days. If somebody's having a good day, they might still be worrying about tomorrow being a bad day. So I think it's about making sure that you know, people are doing the best they can in those moments, and actually how we can approach things with a kindness that are going to hopefully take some of that stress away. I think is something we need to think about. But, you know, absolutely, Nigel, I agree with you. I live with a chronic illness, and if I'm having a bad day, the first thing I feel like I have to do is announce to the group that I'm with, you're going to have to bear with me today. I've got to have that level of self-disclosure. I've got to have that humility, and I've got to present my vulnerabilities. So I'm the one who's, people live with long-term problems are the ones who are constantly adapting to the needs of others, when actually what we need to do is we need you to take some pressure off. And again, not just people living with dementia, long-term chronic conditions. Ask us how we can take some pressure off. I think is really important, and how, you know, if I could help make your day a bit better, what would that look like?
Yeah. Well, condescension and, you know, it'll all be better in the morning doesn't help. And it's a natural reaction, and when people are kind and considerate, I mean, you can tell. You know, you quickly work out those who are genuinely concerned about your welfare, and those people who feel it's just something they have to say because you presented them with something which is quite challenging. Because, you know, it's very difficult to sort of feel compassionate about something you've not really experienced. You know, it's hard, it's a skill.
That's what's empathy, isn't it? And Emma has got a really interesting exercise, the mirror exercise. I think we're sort of coming to the end of things now, aren't we? But I'd really like Emma to be able to share that exercise. But before we do, does anybody else have anything that they want to say before we come to the end of this?
This would be great.
Yeah. Oh, it's been fantastic talking to you all. I'm learning so much just listening to you. Just every time I have a conversation with either of you, I'm always learning something. Yeah, it's great.
I think we're all learning. We learn from other people is the nicest way to learn, I think, as well.
Yeah.
And learning together. We're learning together. That's the thing. This is not about being judgmental, criticizing each other. Yes, I've used terminology historically. Every now and again, sometimes the term might slip in off the back tongue that I don't mean to bring, but what I've found a safe space in being able to feel like I'm not being judged, know that there's a kindness, and I hope I share that kindness with others, but it's about growth and being able to sit back and think, right, how do we think about doing something differently? How do I think about changing, just small changes that I make that will impact on others, because others will get curious about the words I'm using, and how can we I can share that message. I think that's it. It's about the togetherness, and it's not about being what I encourage others to feel is, don't feel like you're being criticized. You'll be encouraged to be curious about.
Absolutely.
Want to explore. I think.
Yeah, I mean, it's not like pointing someone out because they've said the word dementia patient and saying evildoer, you're an evildoer. It's not about that kind of thing. It's just, I guess, leading by example and trying to change the culture of things. We all come out with things that we perhaps didn't mean to say, and I've certainly done it. I've certainly made so many mistakes in my career. I don't think any of us could say we haven't, but it's about learning, isn't it, and changing that culture.
Absolutely.
Nigel, any last words?
These activities are so important. These activities of getting the message out to people and sharing the same road and setting the journey together are so important. They're as important as equally as important as promoting the voices of people with a diagnosis and people affected by the diagnosis. My dementia is everybody's business because I can't leave it behind. I wish I could, but I can't. And conversations like this won't cure my dementia, but it will change the world in which I live, and they're worthwhile.
Thank you. Thanks. And thank you for everyone for being here today. It's really important. I think what we want to end with really is Emma sharing the mirror exercise for the people, for us, because I haven't heard this before, but also for the people listening or watching this vlog might be helpful for you. And thank you for listening. Take it away, Emma.
So through the vlog, we've picked up on a couple of words that we use, that we think about, can we shift and change some of the words we use. So we wanted to actually bring you a little bit of a safe space practice to be able to think on your own in situations or after situations in order for that growth to kind of happen and to facilitate yourself with some questions. So a mirror exercise is exactly what it says. It is with an aim to explore the meaning behind communication, to listen to the content of that communication, and to consider whether our words are factual, positive, and strength-based. So first of all, what I'm going to suggest is creating a curious space for yourself. So you can either actually use a real mirror, or you can use an imaginary mirror. I quite often, you'll see me, I use my hands a lot. I imagine I've got a small handheld mirror in my own hand. Take a moment to look in the mirror and give yourself some permission to be your own critical friend. And when I say about being your critical friend, be a kind critical friend to yourself. It's really important that we show ourselves a kindness. And you're going to be curious about what you say. So what you're going to explore is not going to have self-judgment. It's going to have a reflection in it that you should also celebrate, because every time we reflect, that's a celebration of us growing. Every question we ask ourselves should be a celebration of how we're growing. So use your mirror and then think to yourself, something that you are about to say or something that you have said. Say it to the mirror, look in the mirror and see yourself say it, and listen to yourself carefully. Pick up on some of the words that you've used and be curious about them. You've seen some curiosity go around the room in the vlog today and us picking up on individual words. So try to pick up that up in what you've said and be curious about some of the words that you've used. It might help to write them down or pop them into a little shelf in your mind. And what I'd like to invite you to do is just to ask yourself some thought questions. So when you say the statement, think to yourself, how would this make this person feel if they heard me say this? How does it make me feel about the situation? The information you've heard, was the information accurate? Was it factual? Because that's really, really important. Or was it opinion? Does it sit somewhere else? Was the context of the conversation or the statement based on medical information? Or did it contain a holistic view of the person in the situation? Was there a mixture of both? Start to be curious and unpick what you've said. ask yourself if the statement that you've said and you've heard back, did it reflect the person and their strengths as well as their limitations in this situational moment? Because we should make sure that we talk about some people's strengths and how actually we can bring those strengths into our care, our interventions, and our communities. And actually, a really important question is, does anything I've said, does this stigmatize the person in a negative way? So we're still looking in the mirror, and I invite you to also ask yourself, if the person heard me say this, what would it make them feel? Has it been a negative viewpoint of the person? Would they be happy if they heard me say it? Would I say this to the person themselves? It's a very important something to think about. So would I use the same way to describe the person to lots of different people? Would I use it with people who sit outside of the medical profession as well? That's also very important. And does the statements I've heard or said, does this support or hinder the person's self-worth? Does it promote their sense of their their individuality? So once you've thought and considered some of that, I'd like you to, it's a response and action. So now think about, could my language be more compassionate? Could it be more about helping the person's physical, mental, emotional or spiritual planes? Could I talk to the person or their families and ask them or understand the situation better? And a very important one to think about is, who do I need to share this information with? If I can say that it's non-stigmatizing, it's non-labeling and it's holistic, who else needs to be involved in sharing this information with that actually helps promote that person's sense of self? So some questions to think about is just to explore different ways of communicating the meaning by using factual and person-focused and relationship-focused messages. And just going back to there's a lovely book called The Art of Happiness that's written by Howard Cutler and the Dalai Lama. And there's a quote in there that says, when you talk, you are only repeating what you already know. When you listen, you may learn something new. Don't be afraid to listen to yourself and ask yourself some of those questions and pick up what you learn from some of those powerfulness of words.